I have the honor and pleasure to be joined by Dr. Carol Wagner from the Medical University of South Carolina in Charleston. So great to have you, Dr. Wagner, on the Vitamin D podcast for the Council for Responsible Nutrition Foundation. So great to have you, and thank you so much. I know everyone says they're busy, but you're like at the next echelon of busy. So we really appreciate you carving out some time for us today.
Well, thank you for having me.
And if you could tell us a little bit about yourself to start and your background, and then we'll get into some of the exciting research that you're working on in this area of vitamin D, that would be great.
Sure. So I am, by training, a pediatrician and neonatologist, so newborn specialist. And I have been here at the Medical University of South Carolina, MUSC, for the last 28 years. And during that time, I have been doing research in various areas that include vitamin D. I work with Dr. Bruce Hollis, who's been doing vitamin D research for much longer than I have, for decades. And we've collaborated and conducted several clinical trials that have involved pregnant and lactating women and their babies. And more recently, we're conducting a clinical trial with older individuals who are 50 years and older to look at the prevention and mitigation of COVID-19, which has been quite a journey. So some people will say, well, what's a pediatrician doing studying older individuals? And really, I think my approach is my expertise in vitamin D and also as a clinical trialist. So we have embarked on that, and we started that study last July.
And is that a multi-center study? What is the end for that study? Is it an RCT?
Yeah, it is a randomized control trial. It's actually a pilot study, and it's only taking place here at MUSC. And it is involving, we hope, a final number of 140 individuals who, those who start out who were COVID negative initially, and some of whom have stayed COVID negative, and then those who are COVID positive. And we're looking at the association of the severity of their symptoms and also their antibody status. And then, of course, throwing into the mix, we have those who are now vaccinated. And so we're looking at antibody response in those individuals. So it's not a pure randomized control trial, and it never is with a nutrient study, because everyone starts out with different, vitamin D status and
from background levels, correct?
Yes, yeah. Exactly.
And in terms of the sort of hypotheses you're looking to prove out around vitamin D's utility in COVID for the population, can you unpack that a bit further for us from what your hypothesis entails?
Sure. So because vitamin D has a substantial role in not only calcium and bone metabolism, it has a role in immune function. And so we know that really, if you look at historically the literature that surrounded children with rickets and those who had really severe bone disease, it wasn't just that they had poor bones. They also had increased risk of respiratory infections. Certainly the link of vitamin D with tuberculosis was established, in the 19th century. And and now we have exquisite molecular biology to show vitamin D's role in immune function. And so when we're constantly bombarded with viruses, not just, coronavirus, and so at any given time, your body needs to be able to fight viruses, bacteria, fungi. And if you're vitamin D deficient, your innate immunity, so your monocytes and macrophages, don't function as well. And your adaptive immunity, which means your ability to make antibodies to pathogens, is not as good. And so when you're vitamin D deficient, that you're at greater risk of infection. And so our premise was that if we could achieve what you would get, so achieve in vitamin D status what you would attain if you were living in a sun-rich environment, where you're outside in the sun every day and you don't use sunscreen, you have a robust vitamin D status. And so our premise was that if we could achieve that in individuals, that they would have a lower risk of contracting coronavirus, and if they were infected, that their symptoms of the infection would be less and their recovery would be greater. So that's what we're testing in this study. Again, it's a pilot study, and so we're not we call it powered. We may not be able to show all aspects of it, but I think we will be able to look at differences in immune function in this number of individuals.
Super. And then a couple of points there you talked about. One that gets thrown out a lot that the general public may not be aware of is microphage. What is a microphage?
So it's a macrophage.
Or macro, not even
yeah, so it's a white blood cell in your body that fights off. It's like a Pac-Man, if you would, in your blood, and it engulfs. Yeah, so it's a very hardy cell. You want to have good functioning macrophages in your body.
Excellent. And what is vitamin D's role? What is vitamin D's role with macrophages?
So their ability to recognize and engulf pathogens appears to be, their ability to actually recognize the pathogens is one thing, but the ability to respond to that pathogen is what is facilitated by vitamin D. And if you're deficient, your white blood cells, your infection-fighting cells, do not function as well.
And then when we talk about deficiency, for the purposes of this study or as a general scientific medical commentary, how would you define deficiency?
Well, so if you use the Endocrine Society's definition, it's something that we use, it's a metabolite of vitamin D. So the vitamin D that you make in your skin from the sun is vitamin D3, and supplements are vitamin D3. They're what we call the parent compound. And then they're absorbed through the skin into the circulation, or absorbed from your GI tract into your bloodstream. And then vitamin D, the parent compound, is then broken into a component. It's called 25-hydroxy vitamin D. So it's metabolized, and that compound that we measure in the blood is the indicator of your vitamin D status. And so when so we call 25-hydroxy vitamin D, when it's less than 30 nanograms per ml, that's considered to be deficiency. Now, some laboratories report it as nanomoles per liter, so that would be 75 nanomoles per liter. So either 30 nanograms per ml or 75 nanomoles per liter. But then there are others who think that for your immune function to really be primed, that you should achieve a level of at least 40 nanograms per ml. Which is 100 nanomoles per liter. And we showed that in our pregnancy study, where really in pregnancy, there's a direct link between 25-hydroxyvitamin D and the active hormone. We call it the active hormone, and it gets to be rather complicated. But so there are studies that suggest, not only in pregnancy, but also cancer studies, some multiple sclerosis studies, that suggest you should have a circulating level of 40 nanograms per ml. There's some debate about upper limits, and individuals who have, it seems that those who have levels up to 150 nanograms per ml, it's not affecting their calcium metabolism, but it's possible to have too much vitamin D. It's a fat-soluble vitamin, and so if you were to have too much vitamin D, however you define that, it increases your calcium level in your blood, and first you start spilling more calcium in your urine, and then it increases your calcium level in your blood. But so within a range, the range that you want to achieve is what you would get if you were living in a sun-rich environment, not using sunscreen, going out every day. And if you have darker skin pigmentation, then you're going to see much greater deficiency. And if you look at, in the U.S. and in other countries, those who have darker skin pigmentation, while they are certainly protected against development of certain skin cancers and so forth, they have a much greater risk of vitamin D deficiency. And certainly in the U.S., our African American population has been greatest hit from COVID-19. And if you look at homeless populations who certainly have, social, obviously most would agree that they have an insecure environment, and yet they are out more often than not on the streets and so forth, and they actually have better vitamin D status, and they have not been as adversely affected as our African American population. So it's interesting, and I think at the very least we should learn from this. And this is one virus, right? It's not like we're not going to have any more pandemics or viruses throughout the world, and so we need to be proactive, and we need to stress that however you become vitamin D sufficient, whether it's increasing your sunlight exposure judiciously or taking a vitamin D supplement, you want to have adequate vitamin D so you can be as healthy as possible.
And prepared as possible. Have your immune system as prepared as possible.
Exactly. Yes.
Yeah. Super. And then a lot of what you discussed here in terms of deficiency applies, I assume, to the adult or grown-up demographic. But given your background in pediatrics and pediatric nutrition, et cetera, from a parental perspective, if you're looking to obviously get your kids out of the house as you can, obviously, but what would you sort of recommend to parents in terms of how they should be looking at this in terms of what to give their kids to assist with immune readiness and preparedness?
So that's a really good question. So within the first year after birth, infants can have really good levels, achieve the 40 nanograms per ml on somewhere between 400 and 600 international units a day. So that would be in the typical multivitamin, or there are like D-only preparations that are available. And so that's, really good. I would say up to 1,000 international units during the first year is certainly, acceptable. I wouldn't start out there, but depending on your baby's weight. And we usually, dose in terms of international units per kilogram for children. When they start growing, and you gradually want to increase the dosing. And so probably in mid-childhood, they can easily take 1,000 to 2,000 international units. Now, if a child has a a higher body mass index, just like any adult, they're going to need more vitamin D because the vitamin D, if you have a higher fat mass, will go into the fat tissue. And so you want to have, you will have to increase your intake to achieve a circulating level so that your cells in other parts of the body, not just in your fat mass, would have access to that vitamin D.
Oh, that's great. And then when it comes to maternal transfer through breast milk and lactation, I've seen some statistics on, for instance, omega-3 DHA and how maternal transfer works and some papers on that. Take us through how vitamin D works in terms of maternal transfer and what the mom gives up and needs to retain, and also what the baby needs to get on the conversion and the transfer side.
Sure, those are really good questions. So we've done studies that first started in 2001 in terms of dosing for our lactating women. And so about 20% of the mother's vitamin D gets into her breast milk. But unlike during pregnancy, what crosses over via the placenta to the fetus is 25-hydroxyvitamin D. Remember, that's the metabolite that we measure in the blood. But in milk, in breast milk, it's actually the parent compound that transfers into the breast milk. And very little 25-hydroxyvitamin D gets in. And so what that means is that mothers have to have a steady dosing, because the half-life of vitamin D is much shorter, 12 to 24 hours, whereas 25-hydroxyvitamin D, the half-life is 2 to 3 weeks. So what that means is half-life means how long it's staying in the body and when does it reach its half point after dosing. And so, for a lactating woman to give enough vitamin D to her baby, if she's not going out in the sun, we found that 6,400, 6,600 international units a day affords her enough vitamin D to safely, always talking about safety, to safely enrich her breast milk, and that the baby has comparable vitamin D status to a baby who would be getting it directly. And so for a lactating woman who doesn't want to give her baby a supplement, this becomes an alternative. And we published in Breastfeeding Medicine last year the extensive safety data from the study that we conducted and published in Pediatrics in 2015. And we also had a group of women who were formula feeding on the same dose to show that they didn't have toxicity, because some women may choose to stop breastfeeding or only partially breastfeeding, and we wanted to make sure that if they were on this dose that they didn't get high levels of calcium in their blood. And so that's so we studied over 400 women and their babies, and probably over collectively through the years, we've probably studied around 800 mother and baby pairs. And
wow.
Yeah, so it's
that's pretty extensive, yes.
And there are others who have replicated our study. Dr. Dawodu at the University of Cincinnati conducted a study similar to ours in UAE and found similar results.
Interesting. Yeah, that's quite a data set that you gathered and studied. That's incredible.
Yeah.
Now, when it comes to calcium, because you touched on calcium and calcium in the blood, circulating calcium, one of the frustrations I hear from consumers trying to translate this type of information to something that's palatable for the general public, and we try to make it grade 5, grade 6 level so that it gets appropriately translated and one of the frustrations is dietary and circulating blood intakes are two different things, but we often use the same word. So, digestive vitamin D versus a circulating metabolite of vitamin D, there's correlation. They impact each other, but they're not actually the same thing. So, and that becomes a little more difficult when trying not to scare people off, say, taking calcium versus the risk associated with increased calcium levels in blood in the body. So if you could just touch a bit on dietary calcium versus the implied safety, not necessarily mega concerns, but safety things to look out for when it comes to blood calcium in the body, because they're not the same thing. Could you help clear that up for us a little bit?
Sure. So you have dietary intake of calcium that comes from all sorts of dark green leafy vegetables. Most people think of milk as a source, and that certainly is a source. Cow's milk or any of the as far as, and actually mom's milk, breast milk, is a really good source of calcium, and it's bioavailable. Some people might take a supplement of calcium. So that's the dietary calcium. And then you ingest it and it's processed in your body. And one of the determinants of how much calcium you absorb is actually your vitamin D status. So they're linked. So if you're vitamin D deficient, you're going to not be able to grab the calcium that's in your GI tract as easily, and you're more likely to have calcium deficiency. When you have good amounts of calcium in your diet and you're vitamin D deficient, you can somehow overcome that, right? You could just take more calcium to maintain your blood level. And so your blood level is different than your dietary level. But if you're really vitamin D deficient, at some point you're going to be calcium deficient. And then on the other hand, if you have excessive amounts of vitamin D, so really we're talking about taking probably more than 10,000 international units a day of vitamin D, you're at risk for having a lot of vitamin D, and so you end up absorbing more calcium from your GI tract and so that can lead to elevated calcium in your blood. And your body.
Why is that necessary? Why do you necessarily not particularly want that?
So our body functions within a very, very specific range of calcium. So if it's too low, your heart and your muscles don't work very well. Nothing really works well. You end up having thin bones, that sort of thing. If it's too high, that can be also detrimental. You can have call it tetany, where your muscles freeze up. You can be very fatigued. You can have heart dysfunction, arrhythmias, and you can have seizures from too much calcium. And so your body will try to get rid of excess calcium in the urine. So you first start having higher amounts of calcium in the urine. So when we do safety studies on a vitamin D supplementation study, we're collecting urine and we're collecting blood, and we measure urinary calcium levels. It's called the urinary calcium to creatinine ratio. And we also measure the blood level, the serum calcium level.
It's like a cousin to vitamin D in a way.
Yes, that's exactly right.
In terms of how they work together. Very interesting. Well, as we wrap up here, if we could go a little closer back to home to the start of the discussion related to the current clinical study, when do you anticipate it roughly wrapping up? Where are you in the trajectory, and when do you hope to publish, given where you are now with the research?
So we have probably will need another year before because we're doing follow-up of these individuals. And we were required by the FDA to get an investigational new drug number for this clinical trial. So that took some time, and we have to ensure the safety of those individuals we're treating. They were randomized to a multivitamin containing 1,000 international units of vitamin D, or to so everyone. Let me start over again. They were randomized to either 6,000 international units a day of vitamin D3 or placebo, which is 0. And everyone took a multivitamin containing 1,000 international units a day. And so the final amount was 7,000 versus 1,000 international units a day. And
interesting.
So, and
when do you hope to ultimately? I know these schedules shift all over the place, but when are you hoping for sort of top-line results, a clinical study report, publication on the data? What's forecasted for now?
I would say it will take us another year to follow up the individuals, because we had individuals who were still enrolled in the study in January. So I would say probably in late 2022.
Very good.
And
Great.
there's one other thing that I didn't mention, and we should probably add to when we were talking about vitamin D and calcium.
Absolutely.
Okay, so one of the, a lot of systems are involved in calcium and vitamin D metabolism, and one of the key hormones in the body that affects calcium is parathyroid hormone, so PTH. And when you have low calcium, you increase your parathyroid hormone. It's also associated with low vitamin D. So when you have low calcium and it's due to low vitamin D, your parathyroid hormone will increase. And so we look at that as well. So in those individuals who are really vitamin D deficient, they're going to have an elevated parathyroid hormone level. And when you treat the vitamin D deficiency, the parathyroid hormone level, the PTH level, will go back to normal. So that's an important aspect. And it is very much involved with the absorption of calcium in the GI tract. And it's also involved in how healthy your bones are.
Super. Well, Dr. Wagner, thank you so much for your time today. Appreciate all the insights. Very, very interesting topic, and very interesting aspects of your work and what you do. So I really appreciate your time today and being able to translate this for us. Thank you so much.
Oh, absolutely. Thank you for your patience.